Hello everyone, I'm Rwituja, an orbit and oculoplastics consultant practicing in New Delhi, and today's ocular emergency is orbital cellulitis, which is not only sight-threatening, could be life-threatening as well. What's most important is to identify that it is orbital or post-septal cellulitis, figure out the cause and manage it holistically. If someone presents with severe eyelid swelling, which is painful, associated with redness or erythema, protrusion of the eyeball along with pain, double or decreased vision, which may not be apparent initially, you need to check how they are systemically, that is, how sick they look, especially in children, in whom this most commonly occurs. So, in this situation, you need to ask for a history of recent upper respiratory tract infection, which could have caused sepsis, recent sinusitis, trauma, dental procedures, diabetes, or any other immunocompromising status. Now, on examination, you'll have to record the best corrected visual acuity, which would be reduced, the color vision, which would be altered, the measurement of the intraocular pressure, which would be raised, proptosis measurement, if possible, a confrontational fields, which you can do in adults if required. Pupillary function, pupillary reflexes could be sluggish, RAPD would be present, motility would be restricted. Orbital exam may be a little difficult because of the tenderness, but you can check for resistance to retropulsion. On slit lamp examination, you can check for the chemosis. Severe chemosis can cause corneal exposure, and a fundus exam for optic neuropathy or any vein occlusion. Now, the black line represents the orbital septum. So beyond that is orbital cellulitis. The group 3 and group 4 represents subperiosteal abscess and diffuse abscess or a cavernous sinus thrombosis. Now, the difference between preseptal and postseptal is very important because the management changes accordingly. So in preseptal cellulitis, definitely there'll be severe eyelid edema, but there won't be any proptosis, no motility deficit, no vision loss, and the pupils would react normally. So once you suspect this, get a WBC count done, get the blood cultures done, intranasal swabs if indicated, admit the patient, and review the CT orbit. So look for sinusitis, subperiosteal abscess formation, orbital fat stranding, intracranial involvement, and imaging in children is controversial but is warranted if there is poor response to antibiotics or progression of the orbital signs. Now, in an adult, moderately built patient, what you would do is give them broad spectrum empirical antibiotics, which would cover the Staph aureus, Streptococcus pneumoniae, and gram-negative bacilli. So that would be a cephalosporin such as cefotaxime, roughly 500 mg BD, or Tricidate, along with amikacin after a normal renal function test, 250 mg BD or Tricidate. And in case the culture shows MRSA, then that would require vancomycin, that is again 500 mg BD. Now, this would be for 3 days, after which you would switch to oral antibiotics, that is amoxicillin and clavulanic acid, 625 mg Tricidate, along with metronidazole. You would also require to give them analgesics for the edema and the pain. And the pediatrician in children could decide for the steroids, but this roughly gives the dosage in adults as well as in children. If there is any cephalosporin allergy, you would need to give vancomycin along with the ciprofloxacin 500 mg twice a day. Surgical treatment is only indicated if there is any intracranial extension or if there is any subperiosteal abscess which recurs, or if you need a sample for culture sensitivity, and of course in mucormycosis. Now, the complications are vision loss, the abscess formation, involvement of the cranial nerves, and the more serious ones would be meningitis and death, which is rare. So it's important to follow the algorithm based on the clinical signs because this is a completely clinical diagnosis. Especially in children, it's important that you get them admitted, get them managed as sepsis. And of course, we've described the signs on how to pick up and manage orbital cellulitis. So these are the articles for reading further, and I hope that was helpful. Thank you.